Hi, all identifying information has been removed or altered to protect confidentiality. This case is presented in compliance with HIPAA standards. In this case, I am presenting a 59-year-old man with bipolar disorder, current episode depression with anxiety features, complicated by caregiver burden, prior suicide attempts, antidepressant induced mood destabilization, and inconsistent medication adherence. He lives and cares for his mother, who has breast cancer and a significant psychiatric history. He is currently unemployed and is in financial and caregiver strain have worsened his depressive symptoms. At his initial psych evaluation in February 2025, he reported anxiety for approximately 9 years, worsening over the past year, depressive symptoms that had been worsening over several months, anhedonia. He stopped engaging in his art that he likes to engage in, decreased appetite, sometimes just eating one meal a day, racing thoughts and excess worry, panic episodes, probably about 5 in a lifetime, intrusive negative thoughts, passive suicidal ideation the prior month. He also reported a suicide attempt in his 20s following relationship stress. Most recently, he described thinking through a firearm plan in the abstract, but denied intent and denied access to the firearm. He did state that his sister died by suicide as she shot herself on his back porch, which contributed to a lot of trauma, vulnerability, and increased suicide risk. He has failed or not tolerated multiple antidepressants, including citalopram, Effexor XR, sertraline, and fluoxetine. Notably, fluoxetine caused significant activation and manic symptoms, supporting bipolar spectrum illness. This aligns with bipolar guidelines, cautioning against antidepressant monotherapy due to the risk of mood switching. His medical history include irritable bowel syndrome, GERD, migraines, and kidney stones. He reports quitting cannabis 5 months ago with a relapse around Christmas Day, that he did smoke a joint and it caused him lightheaded and dizziness. And he states that he won't ever do it again if he's going to be feeling like that. In January, he had a high-risk visit. He appeared acutely distressed. He was really fidgety, poor eye contact during the interview, restless and hyper-anxious. He did express thoughts of harming himself if his symptoms did not improve. We talked about going to the ER to get evaluated, and possible involuntary hospitalization was discussed. He declined, but engaged in a detailed safety planning consistent with outpatient suicide risk management guidelines. Since initiating lumateperone on January 13th, his presentation has improved significantly. He now has a calm demeanor. He does maintain eye contact. He is sitting still in a seat. He reports his anxiety has decreased from 10 out of 10 to 8 out of 10. He denies current suicidal ideation, homicidal ideation. He has improved ADLs and community functioning, where he's actually getting up and showering now, and he is going to the grocery store just with the case manager that is helping him out with things. He does report intermittent jaw clenching and leg twitching after the dose was increased to 42 milligrams. No abnormal movements observed in session, but EPS monitoring was initiated. His primary diagnosis is bipolar disorder, current episode depressed with anxious distress. This is supported by antidepressant-induced activation, mood instability, depressive episodes in response to atypical antipsychotics. Differential diagnosis considered: major depressive disorder ruled out due to the manic activation history. Generalized anxiety disorder, most likely it's comorbid. Trauma-related disorder is contributory, and medication-induced movement disorders due to starting that antipsychotic. And then akathisia versus anxiety for his movements. Risk assessment, he does have a past suicide attempt, recent passive suicidal ideation, firearm ideation without access, and chronic caregiver strain. Current risk right now is low, acute, moderate, chronic. Plan for him is pharmacologic. He's going to continue his lumateperone, 42 milligrams daily. It is FDA approved for bipolar depression and is consistent with APA guidelines recommending atypical antipsychotics as first line for bipolar depression. His nortriptyline is increased to 50 milligrams, and we are to remember to use cautiously with mood stabilizer on board, monitoring for mood switching and anticholinergic burden. We're using this to help with his anxiety and off-label for his irritable bowel syndrome. It helps out with that. And he does still have his lorazepam 0.5 milligrams as needed. He said he hasn't taken that for the past week, which is an improvement from before. He was taking it, I think, several times a day to make it through the day. And we did start benztropine 0.5 milligrams nightly for the EPS symptoms. Monitoring includes the EPS surveillance, mood switching, metabolic labs, suicide risk assessment, non-pharmacologic, ongoing psychotherapy consistent with guideline recommendations for combined pharmacotherapy and psychotherapy in bipolar disorder, behavioral activation and graded exposure, safety planning with aligned with National Suicide Prevention best practices, coordination with PCP for his IBS and GERD symptom management, analysis of case complexity using the trigger step. I analyzed what made this complex case and why it matters. Dimension 1, ethical and safety complexity. There was some tension between respecting the autonomy of the patient and ensuring his safety when he expressed his suicidal thoughts, but he declined ED evaluation. This required balancing least restrictive care with risk mitigation. Dimension 2, social determinants and caregiver burden. Unemployment and caregiver strain directly exacerbates his depression and anxiety. There are structural contributors, not just symptom drivers. Dimension 3, treatment resistance and medication complexity. History of antidepressant activations kind of limits the medication options. Medication adherence concerns and possible extraparietal symptoms further complicate management. Repeatedly kind of asking why revealed that outpatient suicide management relied heavily on individual provider judgment rather than a standardized high-risk protocol. The gap that was identified, the gap in care, is a systemic gap. There's no standardized outpatient suicide risk evaluation escalation pathway. Management depended primarily on safety planning and provider discretion rather than a structured workflow, including standardized risk tool triggers, required lethal means counseling, rapid follow-up scheduling, formalized coordination with therapy and case management. This gap could impact patient safety if a high-risk patient is less engaged or has access to lethal means. Primary solution, as a psychiatric mental health nurse practitioner, I would propose creation of a standardized outpatient risk, suicide risk protocol, including documentation templates and defined escalation criteria. Number 2, mandatory lethal means counseling, documentation for moderate to high risk patients, Number three, 48-hour to 72-hour follow-up contact requirement. So just checking on these patients, making sure they're safe, seeing how they're doing, offering that support as well. And then integrated warm handoff to therapy and case management so they know what is happening and we can all collaborate together to help support these patients. Um, in closing, this case illustrates how clinical improvement can occur with ongoing systemic vulnerabilities, and it highlights an opportunity for the psychiatric mental health nurse practitioner leadership to strengthen outpatient suicide risk management. Thank you.